All right, so this is part two of hematological, and we're going to be talking about transfusion therapy. So pre-transfusion, some things you should really be considerate of is number one, of course, have the order for it. Number two, obtain consent. There's usually a specific blood consent sheet that you need to fill out. Then next, you'll need to collect blood and do a type and screen, or probably more likely a cross match where they take the blood, they mix it with the donor blood, and they make sure that it doesn't react. The next thing is gather all your supplies, and then when they send the blood up, usually in a cooler, look at the blood, examine the product, make sure that it is the correct stuff, that it doesn't have like air bubbles or discolors or anything funny. And then, make sure that you identify the right patient, right product, and just treat it like a med. So, make sure that you explain this procedure well to the patient, that they understand that they're getting a blood product, that they should report any signs or symptoms to you, and make sure you know what some of those are. Some of the big things that you might see would be a headache, a rash. They just feel weird. Another big thing is back pain, as those cells are lysing and they cause um, gumming up of the works basically inside of those kidneys. Make sure that you get vital signs before to get a good baseline and then do your vital signs according to policy. Most that I've heard of is like every 15 minutes for the first hour, every half hour for the next hour, and then every hour after that. Um, you can increase the rate at which you go once you start going, but most of the time, what I see is that people kind of stay at a steady rate. Usually, you give PRBCs over 2 to 4 hours is what I'd say. If they're coding or something like that, then of course that's a different situation. You're gonna have to do them way more rapidly, and then of course watch for those adverse reactions. But it is also important for you to tell your patient, and so that they can help you watch for those reactions as well. So what can we all give? What are some of the blood products? Well, PRBCs is probably one of the most common ones we give, and that's to replace blood loss. So we have to match on that one ABO and RH. So that would include, A positive, B negative, AB, and O. And so RH is positive or negative. The next type we give is platelets. Platelets are given for active bleeding, a scheduled procedure, or when a patient's got low platelets. And so this can be given, and it's often pooled from several donors. The next one is FFP, and so this is going to replace blood volume, the clotting factors along with it. You do need to match the ABO type with this one and make sure that it's not going to react in your patient. The next one is granulocytes, otherwise WBCs. This is pretty rare. You might give it on an oncology floor though. This is often diluted in plasma. And then the last one is autologous blood. And autologous blood is something that's been collected from the patient and is being returned to the patient. So transfusion reactions can happen all different types. We talked about some of those. Um, you can be febrile, you can be hemolytic where your cells are lysing. It can be an allergic or bacterial type of thing. A reaction that isn't as bad as circulatory overload, and we can see that worsening with congestive heart failure or sometimes with bad lungs. And then you can get graft versus host. So prevention of these things include use of leukocyte-reduced RBCs and then irradiating those blood products. Treatment of having these acute transfusion reactions would include, generally speaking, Tylenol and Benadryl, and trying to calm that body down. And oftentimes we give lots of saline to try and keep those veins open and keep the blood pressure up. This concludes part two. If you have any questions, please talk to your professor. Thank you.